Hello everyone, we are back with another session with Hirad EP. As usual, please subscribe if you find these materials, these presentations helpful. And we're going to continue to review the latest Afib guideline published in 2023. Now we are in part 6. And we're going to talk about catheter ablation and what are the indications for catheter ablation. So let's get to it. So catheter ablation for atrial fibrillation is one of the effective treatments that we have these days that can decrease the burden or sometimes even cure the atrial fibrillation in some of the patients. In patients with symptomatic atrial fibrillation, if you have symptom and you're not able to take antiarrhythmics or antiarrhythmics are being effective or you're not prefer to take medications or you have side effects from it, then is a class 1 indication to proceed with catheter ablation to improve symptoms of atrial fibrillation and decrease the burden. And multiple recent trials, randomized control trials, which are the strongest trials that we have, shown that ablation for atrial fibrillation is more effective than antiarrhythmic drugs for both persistent and paroxysmal. So both types, the type that is paroxysmal means you get it and for a few hours then it's terminated by itself, and the one that is persistently in atrial fibrillation. For both of them, catheter ablation is more effective than rhythm medication. Now in selected patients, especially younger people, which they don't have comorbidities as many as the older patients, you can consider catheter ablation as a first line of therapy to improve symptoms and reduce the progression to persistent atrial fibrillation. So here, in younger patients, we get extra benefit of reducing the progression to persistent atrial fibrillation. About 10 to 20% of the patient in paroxysmal atrial fibrillation with time, they become persistent. And more you wait, you have a less chance of being effective in treatment of atrial fibrillation and being successful. In patients that have atrial flutter, which is a different type, especially the type that looks like coming from the right side, ablation is also very significantly decreased and can cure the arrhythmia. So for those patients, it can be a first-line therapy as well. But if you're doing atrial fibrillation ablation and then you just want to do that special line that we call it CTI line, so you add a line in right side as a prophylaxis, that shows not improve the outcomes. But if you induce atrial flutter on the right side, or you have a history of atrial flutter on the right side, ablating both fib and flutter improve the outcome. So that is important to remember. Other things like if you have supraventricular tachycardia, arrhythmias like AVNRT, AVRT, of course at the same time that you're ablating the pulmonary vein, you're isolating the pulmonary vein, you can also ablate those and that improve the patient's symptoms and outcome as well. And there's a class 2A here, as you see, class 2A, let me get my marker, that if you're not young, you still have some comorbidities, still there's some benefits of doing catheter ablation versus rhythm management. And finally, earlier implementation, if you do the ablations earlier in the course of the disease, you have a better chance of success. All right, so let's see. In this slide, I want to quickly go over some of the data that we have, some of the important trials in this area. Quickly, I know I just wanted to be brief and then give you some insight on the trials if you're interested to read more. So first one, we have Stop Afib RCT that failed at least one antiarrhythmic, and the patients have paroxysmal atrial fibrillation. The patient had a cryoablation versus using another antiarrhythmic. The success rate was significantly different. So 70% success rate versus 7% in 1 year. So that was huge. So patient that got a cryoablation versus a rhythm medication, they have a significant improvement. Then we got to this Cabana trial, which was very difficult to enroll the patient. Same thing, the antiarrhythmic was enrolled versus ablation, and there was significant reduction in burden and ablation arm up to 50%. So 50% reduction of the burden. So if you have a 70% burden, down to 20%, 50% almost none. And the third trial that I wanted to talk about is a prophylactic catheter ablation of CTI in patients without documented or inducible atrial flutter. That shows there's a minimal benefit, so it's not encouraged or it's not recommended to just ablate people if there's no inducible flutter or there's no history of flutter in previous encounters with patient. And the last two was focused on the early Afib trials, like doing as a catheter ablation as a first line of therapy. And that's a Mantra Afib and East Afib net, especially the post-hoc analysis showed that rhythm control, although it's very good, either using catheter or antiarrhythmic, you can decrease all the bad stuff in the future, cardiovascular death, stroke, heart failure, hospitalization, all those kind of stuff. But in some of the patients that we will talk about in the next slide, earlier catheter ablation would be considered as a first-line therapy and the patients will benefit. Okay, so let's go and talk about those patients. So let's talk about what category of patients will benefit the most from catheter ablation sooner than later or as a first line of therapy. One is younger patients, anyone that is younger than 60 years old and they don't have many comorbidities, they benefit the most because also you can prevent the progression of the disease, and we have a lot of evidence that sooner you take care of the atrial fibrillation, you decrease the future disaster and future issues. The second group is the group of the paroxysmal atrial fibrillation that the left atrial size is not huge and they have a high CHA2DS2-VASc score of like 3 and above. So if your LA diameter is less than 5 centimeters, so you're in the mild to moderate category of left atrial enlargement in the setting of paroxysmal atrial fibrillation, you will benefit from early on catheter ablation. And the third group of the patients are patients with the heart failure that we have from Castle. We have with multiple trials that we're going to get over, and we talk about it later on in the next few weeks. Patient with the heart failure, especially reduced ejection fraction, also might significantly benefit, and they might have a mortality benefit from atrial fibrillation ablation. We'll go over that. So favorable, younger, paroxysmal with the small left atrial size, and patient with the low ejection fraction. And not favorable, patient with the infiltrative cardiomyopathies, more like amyloidosis, cardiomyloidosis, one of them AL and TTR, that the benefit that you get from ablation is not same as other folks. And if you have a severe mitral stenosis or severe valve disease in the mitral area, you might not get benefit like the people with no such a comorbidities. And last one, people with the severe or right side issues like cor pulmonale. So also those patients, they don't get benefit. All right, so for this week, we finished the introduction to catheter ablation. For next week, we'll get a little bit more on what type of strategies and techniques it should be used for atrial fibrillation catheter ablation, and then we get to a little bit more details then. Again, thank you again. Please do not forget to subscribe, and see you next week. By the way, happy Persian New Year. Bye-bye.